If you've ever watched high school sports, chances are you've seen them before. They're the ones running out from the sidelines or dugout or bench to help an injured or shaken up athlete. They are certified athletic trainers, and they play a big role in a team's success both on and off the field. From game day preparation to off-season conditioning, they've become as much a part of high school sports teams as the coaches. And as athletic trainer Jennifer Wysick of Knock High School can tell you, her job involves quite a bit more than bandages and ice packs.
Yes, especially in this day and age with the technology that we deal with, legal liability that we have to deal with, the amount of athletes that we're dealing with. There's so many more kids playing sports at a higher level. Our job is multifaceted.
Here in Pennsylvania, certified athletic trainers are considered licensed healthcare professionals. They must be able to identify and provide initial treatment for everything from minor injuries like sprains and bruises to major injuries like concussions and broken bones.
Besides the regular things that we use every day, the taping and everything that everyone's pretty familiar with, we are computer-based, technology-based as a huge part of our job now. We have cell phones, and we use Impact as computer-based, and all of our filing, electronic documents, everything goes on the computer. And it is amazing the amount of technology that we have to utilize in our job every day that people probably have no idea that part of it.
And although there is nothing like catching a winning touchdown pass or hitting a walk-off home run to make you feel like a pro, Jennifer knows that her student athletes appreciate that they get the same level of care that the pros do.
That is great, but it obviously keeps us on our toes. We have to really know our stuff, because these kids and these parents are coming in with maybe not all the knowledge, but some of the knowledge. So they ask the right questions, and they know what needs to get done. And so if you're not keeping up with that, they know it.
Jennifer is one of the more than 70 athletic trainers at UPMC Sports Medicine who display their dedication daily to athletes at more than 40 high schools and colleges in the area. To learn more, visit upmcsportsmedicine.com.
Athletic trainers must continue their education through programs and training. Athletic trainers also must maintain certification in CPR and emergency first aid.
In college and in professional sports, there are always several athletic trainers who can attend all practices and games. In high schools, there is normally one athletic trainer who must pick and choose which practices and games to attend based on the risk of injury.
Legal and insurance issues. Athletic trainers must keep records for medical and personnel information. They are required by HIPAA and FERPA to keep all records and information private. FERPA protects medical and educational information of patients or athletes. HIPAA defines the rights and confidentiality of individuals and their medical records.
Athletic trainers are supervised by team physicians, but are the first people to respond to the injured athlete. However, team physicians will diagnose the injury of the athlete and make the final decision on the return of the athlete.
Since the 1980s, the need for sports medicine has increased due to the increase in participation in sports and the variety of sports available. Sports medicine physicians are a strong component of the athletic medicine team and work alongside cardiologists, nutritionists, physical therapists, psychologists, and many other healthcare providers, each playing an important role in sports medicine.
A thoracoscopy is a procedure commonly used for the joints of the knee, shoulder, and hip to examine and treat damage to the interior of a joint. Orthopedic surgeons are usually the ones who perform the surgery and evaluate the torn, floating, and torn surface cartilage, and also the ACL of a knee joint. If the surgery is a success, the recovery time is reduced and the surgery rate is also increased.
Anterior cruciate ligament reconstruction, also known as ACL reconstruction, is a surgical procedure that uses a graft replacement of a torn ACL in the knee. A torn ACL decreases the ability to use the knee joint. Since torn ligaments do not heal, medical surgery is often required. Nearly all ACL reconstruction is performed using an endoscopic surgery. ACL reconstruction requires a tissue graft from another part of the body. Two common parts used are usually the patella and hamstring. Ulnar collateral ligament reconstruction is a surgical procedure in which the medial elbow must be replaced with a tendon from another part of the body. Ulnar collateral ligament is often damaged by a throwing motion. During this procedure, the tendon used from somewhere else in the body is woven in a figure-8 pattern through tunnels that have been drilled in the humerus and ulna bones that are located with the elbow joint. This is also known as Tommy John surgery. Before the patient can begin throwing again, a rehabilitation process must be undertaken. During this rehabilitation, ROM and resistance training are performed for 6 months. Articular cartilage covers the end of long bones and helps provide contact and movement for those bones. Articular cartilage is formed by cells known as chondrocytes. Autologous chondrocyte implantation, also known as ACI, is used to repair defected articular cartilage that is often in the knee. Patients must have some of the following symptoms to be eligible for treatment: joint pain, swelling, catching, or grinding. The treatment is given to patients between 15 and 55 years old. These patients must have a minimal to no knee joint damage. These patients also do not need a knee replacement, but are experiencing enough pain to affect sports performance or everyday life. Magnetic resonance imaging, X-ray evaluation, and arthroscopic examination are used to identify eligible patients.
Once a patient is determined to be eligible for ACI, a biopsy sample of between 200 and 300 milligrams of the patient's articular cartilage is collected. The tissue is then sent to a laboratory where the chondrocytes are separated from their surrounding cartilage and cultured for 4 to 5 weeks, generating between 5 and 10 million cells. The implantation of the cells is a surgical procedure in which the patient's joint is exposed by the orthopedic surgeon. The defect area is prepared by removing dead cartilage and smoothing the surrounding living cartilage. The cultured cells are injected by a surgeon under the periosteum, where they will grow and mature over time. In about 10 to 12 weeks, the patient can put full weight on the knee, but complete recovery may take up to 1 year.